Okay, so I think that's everybody that's joined us. So good afternoon. I'm Hannah. I'm your facilitator this afternoon for the session on fertility. Welcome. Just a little bit of housekeeping up front. I'm actually going to mute everybody in the background, although in fact everybody's already muted, so that's brilliant. So the only voices that you should be able to hear over the next sort of 45 minutes will be myself, Jess, and Dr. Carole Gilling-Smith. And that's just so that everybody within group gets the full experience of today. I'm also going to move it so that you see that the main speaker is at the front, so hopefully you get to see the lovely face of the lovely speakers that we recognise. Bear me a moment and I'll move to that format. Okay, so this afternoon, I'm sorry, I think we've got a bit of a tech issue there.
Are you trying to switch to speaker view, Hannah?
Yeah, so I'm just trying to move it so that we've got all three of us there.
Yeah, I don't think we can do that. It's whoever is currently speaking, maybe? Okay. I don't know.
We'll try.
I think you can spotlight different people.
Right, okay, that's fine. I'll do that then. Okay, so good afternoon. My name is Hannah and I'm your facilitator this afternoon. I'm joined by Jess, who is one of our guest speakers this afternoon, waving that at you nicely. She was diagnosed with chronic blood cancer at 36 and she found Shine Cancer support within months of diagnosis. This changed everything, finally meeting people of her own age who had the same struggles, working, dating, living on their own, to name a few. Jess has been a network leader with our London network now for 4+ years and is passionate about using her experience to help other people in the room. Today, she'll be sharing her experiences and challenges in relation to fertility and IVF. We're also joined today by Dr. Carole Gilling-Smith. Welcome, Carole. Okay. Carole is the founder and medical director of the Agora Clinic in Hove. She graduated in medicine from Cambridge in 1984 and is a fellow of the Royal College of Obstetricians and Gynecologists. Over her career, she has acquired extensive knowledge and experience in the field of reproductive medicine and fertility. And today, Carole will share that experience with you. And finally, myself. My name is Hannah. I was diagnosed with Hodgkin's lymphoma in 2014 and initially told that my fertility wouldn't be affected and wasn't the priority for my treatment. Sadly, my initial treatment didn't work. And as a result of that, I had to try and do some salvage chemo further down the line. I made the decision to put on hold that treatment so that I could try and do some fertility preservation. Sadly, that was unsuccessful for me, but at least I had a try. There are options still available to me, but I'm looking forward to finding out some other options from Dr. Carole Gillingsmith this afternoon. Since then, I've had a stem cell transplant and I've also had a relapse, so my fertility is probably in a worse position than it was when I initially started. So I understand firsthand how hard talking about fertility is, and the various avenues are often limited to others. And peer support often lacks that empathy and can be frustrating due to unhelpful comments. So we hope that this afternoon will be helpful to you. For the next 45 minutes, Jess will be giving a presentation and then Carole will also be giving hers. And then at the end, there will be the opportunity to ask some questions. So as questions pop up, if you want to pop those into the chat for us as we go through, I'll collect those and then we'll move to questions at the end. So thank you very much, and I shall move over to Jess.
Hi, everybody. I am going to try and spotlight myself so that you can all see me.
I can see you, Jess, actually.
Okay. Hopefully you can all see me. I don't know, like, hi.
That's working.
So my name is Jess. I'm one of the Shine network leaders in London. And I'm going to talk for just under 10 minutes or so about my personal experience. So I was diagnosed with incurable blood cancer when I was 36 in 2015. And as most of us on the call will either have cancer or be a +1 of somebody that has got cancer, all of us are aware that it can affect your fertility. So I actually was fortunate in that my fertility hasn't been affected by my cancer treatment. I want to make really, really clear at the start that all of this affects all of us in different ways. It can be extremely upsetting and triggering. So if you need to take a step away from the conversation, or basically, take 5 minutes, you can leave, you can join again, whatever you need to do to look after yourself. Don't feel because you've joined, you've got to sit here and listen to all of it. And I do appreciate my situation might be very different to yours, but we will be hearing from Hannah and also Dr. Carol to give the kind of complete picture. So I was able to undertake fertility preservation very soon after I was first diagnosed. That meant that I spent about 3 weeks doing the kind of all of the injections, going up to harvesting, and was having extremely high doses of the follicle hormones to stimulate egg production. Without kind of going into too many details, it was mismanaged a little bit, and I ended up being extremely ill afterwards, developing ovarian hyperstimulation syndrome because I have polycystic ovaries, and actually ended up spending a week in hospital in kind of a high risk unit, and it then took me another month to recover before I was able to start my treatment. So on one hand, it was successful. I was able to produce a lot of eggs, which were then fertilized and made into embryos. However, I was on chemotherapy when I had the treatment already. So it's highly likely that even though I ended up with 9 embryos, because they were frozen immediately at day 1 and they weren't grown into blastocysts, it could be that all of them have been corrupted by the chemo, so all of them are useless. The only way I'm going to know that is if they're defrosted, grown, and then seen if they kind of take. I should also mention I was single when all of this was happening. So I was able to get the eggs fertilized by using a sperm donor. Now, I think it's fair to say when people think of having a family, nobody really kind of dreams of having a anonymous sperm donor as the other parent. I can see some hands saying I do, or maybe like she's maybe done this as well. But for me, I found it extremely upsetting having to use a sperm donor, and in a lot of ways that was the hardest part of all of this. I've since then come to peace with it, and actually I'm really, really happy. Becky, I can see that you've raised a hand, and I'll come back to you if that's okay as we kind of get to the end of my session. So I was able to use a sperm donor. I had to pay for that part of the process myself. All of the IVF was funded by the NHS, which was very fortunate. And it was also fortunate because of where I lived, I was able to use the sperm donor and actually get the operations done at a private clinic. But that varies wildly depending on where you live in the UK. We'll probably come on to funding and any questions around that later. So I chose the donor, used the donor, got my 9 embryos, started my treatment. I had a 2-month, very, very high intensity every day chemo. Then it went down to once a week, then once a month. And I did that for 2.5 years. So I actually wasn't able to even consider using the embryos until I was 38. Now, some of you may know that in some parts of the UK, 38 is the cutoff age for NHS funding. In other parts of the UK, that age is 40. In a few parts of the UK, that age is 42. I'm now 42, believe it or not. I know I look a lot younger. But seriously, I wasn't told about this cutoff. which then meant that I wasn't entitled to get funding for the second part of the process. The first part is the most expensive, but if you actually want to use the embryos, you then have to do a lot of other things to kind of get there. So that hit me really hard. I felt very kind of betrayed by my doctors, because my fertility specialists, my cancer specialist, my GP, my psychologist, like everybody that was involved in my medical care, not one single person let me know how to, you know, what the next stage was. So you do the cancer treatment and then what? My fertility has also changed a lot in that time period, being over 40 now. But because I'm polycystic, I do still have a lot of eggs, but they are very old. And what that means in practice is that, genetically speaking, even though I've got loads of eggs, the eggs that I've got are very highly likely to have genetic abnormalities, which reduces the chance of my success. So in the last couple of minutes, I just wanted to share that I have this year done another round of IVF. I was able to use the same sperm donor as I used before. I did consider using another sperm donor, but there weren't really any others that were anywhere near as good a match for me. And I'm very happy to answer any questions on any of this later on. I do have a partner now, a long-term partner, and having the conversations with him about how he would feel about fathering a child and raising a child that wasn't genetically his was extremely complicated and extremely emotional and, quite frankly, traumatic for both of us, because, again, nobody really dreams of this as like the ideal way to starting a family. So I'm kind of making a few jokes here, but I cannot underestimate the impact psychologically all of this had on me. It is 100% caused kind of depression and anxiety. I still haven't completed IVF, so I've done another cycle. I do have, I think, 3 embryos now that are healthy blastocysts with the sperm donor that have been frozen. My partner has now, because we've been together for a bit longer, we've decided that we are going to try and do one last shot at IVF to try and get some embryos using his sperm. But if I was betting, I would kind of, yeah, thank you, fingers crossed. If I was going to place a bet, I would guess that his sperm is not going to be anywhere near as good as the sperm donor, because he is 43. He has got his own health issues. Fertility does decline in men with age as well as women, although not in the same way. There's lots of different issues with using his sperm over the sperm donor. The sperm donor has like the highest sperm count in the entire universe, because, you know, that's who the clinics go for. It's people who are going to have a very, very high likelihood of being able to conceive. So who knows what the future is going to hold. I'm going to probably pause it there. I'm going to hand back over to Hannah, but I do want to make really, really clear that no question is off limits. Like, if you're kind of a little bit embarrassed, or you're not sure if it's an appropriate question, or, you know, you've got a different experience or a similar experience, like, literally ask me anything. And I reserve the right to decline to answer, but no, seriously, you know, ask me anything. I'm very, very open. I wish I had heard a talk like this before I did all of this. So we're here for you today to try and help you and answer your questions and concerns. I think I saw that Becky raised her hand during the chat.
Yeah, I've asked the question, Jess, so I'll come to the questions at the end, if that's okay.
Yeah, perfect. So hand in now, back over to Hannah.
you so much, Jess. That's much appreciated. So thank you for giving us an insight into your world of fertility. I shall pass over now to Dr. Carole Gilling-Smith. Thank you. Welcome, Carol.
Can I share my screen?
Yeah. Oh, yeah. Just bear me a second. I've probably not enabled that. Bear me 1 second. Should be able to now, Carol.
Thank you. So thank you very much, Shine, to consider me as a speaker and to invite me. Really very important part of the work I do is to educate people. And you know, I'm a consultant gynecologist. I've spent, as you could hear, the best part of my career trying to help people conceive. And the wonderful thing about the last 10 years is I think we've become more attuned to being able to do things that we couldn't do before. And one of that is preserving fertility. And I help people through the NHS in a lot of cases preserve their fertility before starting cancer treatment, and also people before transitioning and taking hormones that might damage their fertility. And it's lovely also to then see them come back to be able to start that pathway of having a child. And I think the story you tell is one of perhaps lack of information, lack of support, and very, very frustrating. I have a particular association with cancer. My husband lives with cancer. Thankfully, he was diagnosed later. He was diagnosed in his very early 50s with advanced prostate cancer, and so we'd already had our family. But I just lived, and I continue to live what you're going through, because his cancer, you know, was advanced. He was told it was terminal, and you know, thanks to continued new treatments, he's with us and you know, continues to be well and able to lead a very active life and family life and professional life. But I do have a particular passion to help people find the best way to have a family and live rich and fulfilling lives alongside whatever's happened to them as a result of the cancer. So that's where I am. I'm in Brighton, which is a lovely place to be in, and the top floor of that building is where the clinic is, and we do both NHS and private treatment. So what I'm going to talk about is the routes to fertility preservation. That may not apply to you, but at least I want to cover it as part of what I want to do. How to manage your fertility when you're on cancer treatment or beyond that, your future options, whatever's happened to you as a result of treatment, a bit about LGBTQ plus parenting. I mean, being somebody that believes very much in inclusivity and diversity, I'm very much here a clinic of whoever needs our help will get our help, and then the patient support options. So just starting at that point of diagnosis, your options really, if you're given the chance to freeze your eggs and sperm, are really important to take that chance, discussing it with the oncologist as potential risk of the cancer treatment on your future fertility. And sometimes, as you heard in that wonderful talk, you may be better off getting some your partner's sperm or donor sperm and creating embryos. There's something nice about knowing that that's a fertilized egg that you've stored. The pathway to parenting really starts at the point of diagnosis, where you really don't want to be thinking about fertility. That's the last thing that's going through your head. But a good oncologist should always open your eyes to the fact that there will be a fertility clinic in your area that can, under the NHS, unless you've already got children, will be able to offer fertility preservation of eggs or sperm, and a chance to have a rapid referral and to chat and discuss whether it's something for you or not. And that is really important. And if they haven't asked that, it's a failure. The next step is to have that referral and chat to a specialist like myself. And if you want to preserve your fertility, to have that little window, and we can do it within a short space of time. Then, you know, don't assume your fertility will be lost. The different treatments that are available are not all going to damage your cancer. Obviously, stem cell transplant is probably one of the ones where, yeah, there's a good chance it will, not in everybody. And it may, though, because the whole total body irradiation is quite an important step in that. But most cancers we see 95% of sperm recovery. 70% patients will get full recovery of their egg reserve. Childhood cancer is perhaps another area, but where you may find that you recover your fertility after treatment, but you're more prone to an earlier menopause. So it's kind of really important to be so fertility aware after treatment. And then if you don't conceive naturally, then it's the time to come back and say, well, that was my backup plan. I did a belt and braces approach. I put some eggs and sperm in the freezer. I haven't been able to conceive naturally, or I haven't found a partner. I need to go through some IVF. If you check your egg reserve, it's not good, or your sperm count is not good, you've done that. You've got that in the freezer safe, and you can go through assisted conception treatment and IVF. And then if that doesn't work and you haven't perhaps preserved your fertility, the assisted conception, it can offer things like egg donation or sperm donation. I can't cover all of this in a small space of time, but I'm going to start by making sure you understand the principles of what is going on in the sperm part of your body or the egg part of your body. So the women make their eggs before they're born. So they have their everything done and made halfway through your mother's pregnancy. You make all your eggs, you have about 7 million. And by the time you've come to be born, you've actually only got 2 million. You've lost most of your eggs, funnily enough. Nothing can change that. And by the time you hit your first period at puberty, you've got about 400,000 eggs left. That kind of decay of eggs is a natural process. It's quite rapid in the first parts of your life. It's an exponential curve, and it sort of steadies out during your reproductive years. Now, fertility in terms of cancer continues to decline at a steady rate, with under the age of 35, pretty good egg quality being maintained, irrespective of what's going on in your chemo or whatever, because egg quality is good. And that's the same if you're not having any cancer treatment. Beyond the age of 35, you start to see more errors occurring in the eggs. And most women will start to see a decline in their fertility in their late 30s, early 40s, and go through a menopause, sort of average age of 51. What does cancer treatment do to the ovaries? Well, it depends on the cancer. And if you have your cancer in childhood, some of the leukemias and blood hormones tend to use slightly more aggressive regimens that can have more of a toxic effect on your ovaries, kind of bringing this whole clock forwards. So leading to perhaps a menopause in your 30s or even 20s. So even if you've had cancer treatment, doesn't mean to say you can't preserve your fertility. Once the chemo's over and your body is clear of the drugs, you can do it, because you just need to be aware that you might go through an earlier menopause. So it's worth thinking about. But if you can do it before the chemo, it's always even better. Obviously, if you're a child, you can't preserve your fertility in those years. You're going to have to wait probably till sort of 18, 19. So how do we assess your fertility? We know that we're losing eggs, but we're also waking up eggs all the time. So what we do to assess your fertility, and we do that to everybody who comes to the clinic, is we do a scan of the ovary. And you see you're waking up eggs. It takes about 3 months for an egg to go from just a dormant egg in your ovary to a little egg that sits in a sac of fluid. So we count your little sacs of fluid. That is the way we can tell how fertile you are. Any point in your reproductive life, before treatment, after treatment, at any stage, we scan your ovary, we count the number of woken up eggs, because the number of eggs that are awake is proportional to the number of eggs that are still asleep in your ovary. And the little cells inside these sacs of fluid make a hormone called AMH. And as you heard about polycystic ovaries, well, actually women with polycystic ovaries might be more prone to irregular cycles and things, but they tend to have more antral follicles and actually be more fertile and got a bigger stock of awake eggs. But this number, the higher your AMH, the higher your antral follicle count, the better. But it's also really important that you see this diagram, because now you understand that each month you have available in your ovaries a whole load of eggs, but you only actually ovulate one in a natural cycle. Knowing that you've got a whole load of eggs is important, because that's how we're able to grab a cycle of egg freezing. So what we do is we measure your antral follicle count and AMH when you come to us. And we know that in a natural cycle, this hormone made by the brain called FSH makes one of your woken up eggs grow and ovulate. And the little sac of fluid grows to about 18. It grows from about 3 or 4 millimeters to about 18 millimeters and ovulates the egg. Well, all we have to do an IVF cycle to freeze your eggs is we have to give you daily injections of these hormones. And that's how we can kind of con the ovary into producing a lot more eggs. So if your antral follicle count is, for example, 14, we could bag 14 eggs in an egg freeze cycle. If it's only 5, you're not going to get as many. You might have to do 2 cycles, and we can sometimes do 2 back-to-back cycles to freeze eggs before starting treatment. So we scan the ovary, we monitor how the follicles are growing, and then we can collect them. Sperm is not made before you're born. Sperm is made from puberty onwards in the testicle, and it is made in a continuous fashion. It takes about 3 months for a sperm to go from a sort of very basic cell to a fully formed sperm. And in a sperm test, we measure the count and how motile the sperm are, and whether the sperm have abnormal shapes. And this is a normal count. So when you want to come and freeze sperm, it's a pretty quick process because you're always making sperm. Now, sometimes your cancer, if it's been going on for a few months and you've been really unwell, can affect your sperm quality, but it doesn't matter. We can freeze the sperm. And even if you had no sperm at all, we could potentially freeze it. So when we do sperm freezing, we get you in, you can see a consultant, and we would be discussing your wishes. What is your cancer treatment and diagnosis? What have they told you about the treatment? Is it radiotherapy? Are you going to have the testicle removed? Are you've got testicular cancer? Are you going to have 1 testicle removed? Are you going to have radiotherapy to the... When we know what you're doing, we'll tell you, okay, whatever you're doing, if you're not going to start treatment, say we're Tuesday, you're not going to start treatment till next Monday, you come to see me, we'll do a Zoom chat. I said, come in, we're going to try and do 3 visits over the next 6 days, and you're going to produce some sperm, ejaculate some sperm into a point. If you want to produce at home, that's fine. Just bring it, just as long as you're within an hour of my clinic, I can get that sperm. We will freeze it in liquid nitrogen in very, very tiny little straws, about that sort of size, really narrow straws. We can get that. And if you think about it, 1 attendance, if you've got normal healthy sperm, will give you enough for, in the future, 6, 7 treatments. And if you can come on 2 or 3 occasions, that's even more. So that's a good thing. We can freeze that. When you come for treatment, when you come to do this, we will go through the risks of, how you would use that sperm in the future, the chances of pregnancy from using frozen sperm. We'll look at the sperm quality. We'll do a sperm test for us. We'll know how much good sperm you've got on a typical, that will tell us a little bit about it. We will need to do tests on you to make sure that sperm can be used in the future, because we're highly regulated in the IVF industry. And depending on how you want to use the sperm will kind of guide us as to what tests to do. But the basic test will be HIV, hepatitis B and C. And if you're sort of orientated towards the opposite sex, the chances are that sperm will be used in a normal heterosexual relationship. That's all we need to do. If you're thinking, actually, no, I'm gay, I really want to have a baby with another man, then we'll think, okay, surrogacy is going to be probably what you need to use. We'll do an additional number of tests, gonorrhea, syphilis, a few additional sexual health screen tests to allow that sperm to be used. Once the sperm is frozen, we'll get you back in 6 months at some point to do the sexual health screen, so that sperm could be used in a surrogate. We have to do very detailed consent forms, which will help and support you through. And also we have this lovely regular dialogue with the laboratory team, so you kind of know what the quality is, what your chances are as you're going through that. If you don't have any sperm, it can be done in a very short space of time. We can sometimes get you referred to retrieve sperm directly from the testicle. I can't say that it's always done on the NHS, because that's often the time scale of doing it, but it was done under sort of local anaesthetic, and it can be done. And we can use that in an IVF process in the future. So the process really of fertility preservation is fertility assessment, doctor consultation. And that same process starts with the egg freeze. Over the egg freeze, you'd probably expect to have a nurse consultation once we've decided what you're going to do before you go on to treatment and go on to your ovarian suppression. When you go onto your cancer treatment phase, if you're having chemotherapy, we usually shut your ovaries down with something called Zoladex. It's basically to put you into a pseudomenopause, because studies have shown that will protect your eggs. We can get all of this done over 2 to 3 weeks. So it's usually a good if we've got the time, most of the cancer treatment patients I see have got that window. Whilst the treatment planning is going on, you're going off for the MRI or whatever to plan whatever it is you're going to have, surgery, radiotherapy. I mean, breast cancer patients often come to me having had their surgery, and they see me in the 6-week window before the chemotherapy is supposed to start. Brain cancer, so more likely to be not having had surgery to start their chemo. They may have only a 3-week window. So we always manage to get it done. It generally, unless you're so unwell that you can't do it, and then you need to think potentially about coming back to do this after you've finished your chemotherapy. We use fertility preservation now. The techniques improved massively in the last 8-9 years. It's called rapid freezing, with very good results on thawing. You can really leave them in the liquid nitrogen forever, but the legal part is 55 years if your fertility is affected. We can create embryos, fertilized eggs, or we use it for donor eggs and donor sperm. So it's a very standard treatment. In a woman, it's a little bit more complex, that process. So you gain rapid referral, 24 to 72 hours within being seen and diagnosed. We then arrange for you to have that AMH blood test and scan, so we know what your fertility reserve is, and we can work out what doses of drugs you need. But again, we discuss your wishes, your future intentions of parenting. If you can put your head around it, I mean, we don't have to discuss it. We could just do it. But if you want to talk about it and say, well, this is what I'd like to do in the future, we really want to open up that conversation. If you've got a hormonal-based cancer like breast cancer, we can use specific drugs during ovarian stimulation to suppress estrogen, to minimize any risk whatsoever of the cancer being influenced in a negative way, which we do. It's called letrozole. We discuss the risks of the cancer treatment on your ovaries and your future fertility. We do the consents and the sexual health screening. Always mindful of how stressful you are, the position you're in with your cancer treatment. So, we talk you through the monitoring. If you struggle with internal examinations, with tri-abdominal scanning, with the egg collection, we use deep sedation. It's important that you're not aware of anything. And this is the process. So you're going to be taking some hormone injections. I'm afraid it's injections under the skin, but there's injections because hormonal drugs are destroyed in the stomach. 3 or 4 visits to monitor your ovaries over 2 weeks to see how your little eggs are developing, your follicles are developing, and then you come in to have your eggs collected. And then we freeze. If you're creating embryos, then we can fertilize them. But in general terms, you're going to be on treatment within a week of being seen, and eggs collected within 14 days of starting your hormones, sometimes less, using 2 types of injections, one to stimulate the ovary, one to block ovulation, of course, to control things. And then you can come back, use eggs or embryos to get pregnant at a future date. You may not need them. They're your backup. So that's how the egg collection's done. Here's an internal scan under sedation, under anesthetic. We are able to put a very, very fine needle through the top of the vagina into the ovaries to pick out and sort of aspirate the fluid with the eggs. This is our laboratory where the eggs can be then checked under the microscope before being frozen. So what can we do with those eggs and in the future? Well, on the left-hand side, you can see a picture of an egg. This is an egg. It's surrounded by very specialized cells that feed the egg. And at a future date, either using donor sperm or your partner's sperm, we just thaw out the egg and we can mix the egg with the sperm. Now, if we do that with frozen eggs, we wouldn't get a good result. That's standard IVF. If ever you want to do standard IVF, that's what we do. So what we have to do is this, which is to actually take a single sperm and inject each egg with sperm. We found that with frozen eggs, that is the only technique that gives high chance of fertilizing the egg, chance of really getting very good results with frozen eggs. So egg freezing technology has really improved over the last 8 years. So this is a single sperm being injected into each egg, and that can be a sperm from your partner or donor sperm. And some people may decide that they're with a partner at the time of their cancer diagnosis. They get all their treatment and they want to freeze embryos. Little risk of that is that the embryo belongs to both you and your partner. You do not have full control, and there have been some cases where partners have actually decided, no, I'm not going to give you my permission to use that embryo to have a child. So generally speaking, we try and encourage you to freeze eggs unless you've been, you know, long-term relationship, you're totally with the person that, you know, is there to support you and to provide the sperm. So once this is showing you the phase of development of an embryo to an embryo stage. So this is a fertilized egg the day after we've collected the egg. This is about 2 days after we've collected the egg. The embryo is about 4 cells. Then we go to about 8 cells on the 3rd day. And then we go down to the 5th day. This is a blastocyst, which is about 140, 150 cells with the eggs, with the embryo cells here. Placenta. This is what we would transfer in a uterus, the day 5 embryo, but it's also what can be frozen as an embryo. So we want to create an embryo at the time of freezing, we can do that, or at a later stage, we can create this blastocyst to transfer into your womb or into a surrogate's womb. If you're somebody who's had cervical cancer and you've lost your womb, or uterine cancer, or you've had radiotherapy and your womb doesn't work, we can use this in a surrogate. As long as we've done the right screening tests, we can do that. And we do this day 5 transfer because that's what gives us super high success rates, like a runner in a race. Who's the best in the race? Who can run the fastest? You can only see that when you've actually got a reasonable length of time in the race. So the transfer is a painless procedure. It's an outpatient procedure. The little tiny embryo is put in a little tubing and very gently passed into the uterus. We do it with a tummy scan, doesn't hurt, and you wait a couple of weeks to do a pregnancy test. So that's the bread and butter of IVF. And you can expect these sort of results in a good IVF unit. The chance of pregnancy is dependent on your age as the woman, not the man, the woman. The woman's age is really the critical factor. As I said to you, if you're under 35, really not much change in your fertility over that time. But if you get older, you'll start seeing more genetic errors in your eggs and more chance of not having a healthy embryo. So your chance of pregnancy go down. If you preserve your fertility when you've been diagnosed with cancer under 35, there is usually very good recovery after the cancer treatment as a woman or as somebody with ovaries. But as you get older and you get into your later 30s, the chances of recovery do go down. It's really important to have that injection treatment, though, to shut down your ovaries during the chemo. Really important. So these are I'm not going to spend too much time on this. You have to make sure all the legal documents are in place. So we're there, the clinic is there to make sure the legal documents are in place. And with your head spinning, we help you to make sure you can sign these consent forms so that your eggs can be used in the future. If you're a man in a stable relationship, you can agree for your sperm to be used if anything happens to you in the future. But you have to be in a relationship and give that consent. So there's more consent forms. These are the HFEA, our regulatory body consent forms. National guidance means that patients whose medical treatment may compromise fertility should be offered NHS-funded fertility preservation. So it's cancer patients or those transitioning. As long as you don't have any living children, you should get that offered to you. The problem is the standard freezing cycle offers just 1 cycle of egg freezing. In ideal world, we'd like to get 20 eggs, optimum number, you know, giving you an 85 to or greater chance of a pregnancy if you use those eggs in the future. Sometimes you just won't get that, which is why we will sometimes offer back-to-back freezing, or say come back after you've done your cancer cycle. Let's just check your fertility and potentially do another cycle. You might have to pay for it. Sperm freezing should be enough, you know, because you've got normally that week. How to look after your fertility during treatment and afterwards? Just really be careful with your diet and lifestyle. You know, as in terms of men, alcohol, recreational drugs, smoking are all negative factors in sperm health, as is heat to the testicle. You know, just be aware of heat, saunas, hot baths, but generally lifestyle is the big one. Get fresh food, not processed food. Make sure you really look after your style. And weight is another big thing. Being overweight can affect sperm health. With women, eggs, because they're made before you're born, you can't do a huge amount. We talk about coenzyme Q potentially having some benefits. Smoking is a no-no. Smoking is the one thing that may reduce your ovarian reserve. There's less data about recreational drugs and alcohol, but smoking is definitely not a good thing to do. But I would say post-treatment, have regular checks on your fertility. So for women, AMH scan, men, sperm test, that's what the clinic's there for. And just be conscious of your age, when to start a family, start having those conversations a lot earlier than you might have thought, just to be on the safe side. If you've got good quality eggs and sperm frozen, then it's obviously your backup, but you want to potentially be able to conceive naturally. So just future steps. Hope I'm okay for time, but just an overview. If you've got frozen sperm, you may get away with using it in just insemination treatment of a female partner, where the sperm is thawed and just placed in the uterus at the fertile time of the month. If the sperm is good quality, you can get away with that, which is cheaper and easier. You may need to do IVF. If you've got frozen eggs, you will have to do IVF. But if you've got frozen sperm, if the quality of the sperm is poor, you would have to do IVF. If your fertility has declined to the point where you do not have the ability to use your own eggs, I think we touched upon that in your case, you may need to have an egg donor. The donor egg would be the person donating eggs would go through the IVF, have their eggs collected, and then be mixed with your partner's sperm to create embryos. And, you may need to use a surrogate if you lose your uterus, where obviously you could be the biological mother, or you could use an egg donor. The partner could be the biological father. And there's more and more. UK surrogacy is now becoming, I do a lot of surrogacy cases now, which I wasn't doing five years ago. If you're from the community of the LGBTQ plus community, you want a parent with lots and lots of support to guide you through same-sex parenting with donor sperm if you're female, same-sex gay males, and trans parenting. So for the future, we can look at all those things. And in case, we've got two dads, very, very much something that we're seeing more and more of, using a donor egg. This is an example of how we always go through what the future holds. This is transparenting. Once you've frozen your eggs or sperm, you could be using, depending on your relationship, donor sperm. You could be using your own uterus. You could be using a donor. So we just go through all those things with you, so you can kind of build a picture. And you can have that conversation at the time you're diagnosed. You can come back and have that conversation when it's all finished and you kind of want to just know, how can I use my sperm and eggs in the future? So we've touched upon this in that first talk. It's a very, very anxiety-provoking time. So we have on the Agora website plenty of resources for you. You'll find there's a doctor's portal where doctors can refer you straight into us for rapid referral. There's a patient portal where you can go and you can refer yourself, or you can just call us. And we've got, I've got some videos, I've got some blogs, patients who've come through and frozen. So it's useful to know that that's there. We've got a great team. We've got lots of patient support options. We've got a closed Facebook group and a patient app. We've got lots of other support. I think you'll get a copy of the slides, but you've got lots of support partners, depending on, your sexual orientation. The HFEA, your Human Fertilization Embryology, has got a good thing on the website. And, we've got really good, a lot of people follow us on social media where we kind of share information. So I'm very happy to take questions, but, wherever it fits into the talks today.
Thank you very much,
Thank
Carol.
you.
That was excellent. I'll open it up for some questions now, if that's okay, both to Carol and Jess. There's quite a few that have come in through the chat function. So I've got a couple that have come through. So the first one is, will obesity in women affect or deny women the opportunity to access treatment?
Was obesity?
Yeah, obesity, sorry.
So it depends. It's postcode lottery determined in terms of NHS funding. So, for example, in Sussex, the upper BMI for fertility treatment is 30, upper BMI, but it doesn't seem to be applied that rigorously in terms of fertility preservation. Most IVF clinics will have an upper BMI of 35 for egg collection, just because it's quite difficult anesthetic wise. So it depends on the clinic. And that's an in-clinic decision. We, for example, we're not able to do above 35 in terms of BMI egg collections because of the anaesthetic risk. So it's because we're not in a big hospital with intensive care facilities, because it's an anaesthetic risk. It's not because we don't want to do it. So privately you could do it with a higher BMI, but you'd have to choose your centre to make sure that they took patients with a high BMI.
The next question we've had come in, and a couple of people have asked this, was, I was never offered ovarian suppression before chemo. So what impact could this have? And is it too late to try and do something about that now?
No, I don't think, different oncologists use different protocols. There was some good studies suggesting that it protected the ovary during chemo so that you would get better recovery of ovarian function. If it's been and gone, there's nothing you can do now. You should just get a fertility MOT, which is very easy. We do them all the time here, just to see where you're at. But there's nothing you can do, to change what's happened.
How would you advise people to go and get a fertility MOT? Because there's quite a few people sort of saying, how do they go about trying to get support or access to support if they live in different parts of the country, for example, in their fertility? We certainly can do an online fertility MOT. The only bit that people need to visit us for is the ultrasound scan, but we can do home finger prick testing. So we developed that during the first lockdown. So we do a Zoom consultation after a finger prick hormonal test. And that in itself would be quite a useful start. But most fertility clinics, and they're listed on the HFEA website, local to you, will do a fertility MOT, and that would allow you to have this ultrasound scan as well of the ovaries to give a more complete picture. And a sperm test, obviously, we also do home sperm tests, which we can send out. But when you've got a very low sperm count, that test is not that accurate. Thanks, Carol. So is that likely to be funded, or would most people have to self-fund that themselves?
They would probably have to self-fund. I mean, we're, for most of our patients, the female fertility MOT is around about £350. A male sperm test in the private sector is about £160. But if you speak to your GP and you ask for those tests, they may be able to organise them through the NHS. In other words, speak to your oncologist and say, if you've frozen your sperm or your eggs, can I just check where my fertility is now, and just see if your GP will support you. But do remember, the most sensitive test is called AMH. GPs need to be told that, and ideally with a scan as well.
Thank you. And then somebody's asked, the 80% statistic for success with 20 eggs, is that from frozen eggs or using those eggs straight away from embryos?
So I quoted data, which is because most egg donation banks are using frozen eggs. So those frozen eggs is giving us a substantial amount of data about how good they can be when they're used in the future, when they're thawed out and used. So when I said that if you were 35 or younger, your optimum number of eggs to freeze would be around 20 to give you a greater than 85% chance of having a live birth, a baby from those eggs. It might allow you also to have a second baby, but those are the statistics that are currently floating around. As with all things, it's making sure you go to a good, reputable centre that knows what they're doing, to make sure that you get a proper assessment, and that the eggs are obviously frozen. So again, the HFEA website will give you a list of licensed centres, and then do your research, have a good look at the centre.
Thank you. I've also been sent a question from somebody that sadly wasn't able to attend today, but we'll be catching up on this, I think, after we've posted it online. But they've been told that my sperm isn't there anymore. I've been advised they can do to see if they can find any sperm. What are the chances of sperm being found, and the NHS or private? Would that need to be done on the NHS, or could it?
I think if you're funded? Yeah, and if you've been treated and your sperm test shows no sperm, there should be a two-step process in the NHS to explore whether you have sperm still being made in the testicle. one is to do a hormone test. We look particularly at the hormones FSH, LH, and testosterone. And the second, and that will tell you if you've gone into a male menopause, if you like, if your FSH is very high, like a female. And the second is to do a biopsy from the testicle to see if there are any sperm, is there any sperm production in the testicle. And you do occasionally find that you'll find some sperm being produced and you can retrieve it. So your ideal place to go is a fertility center, because they can not only do the biopsy, but what they then biopsy, they can freeze so that you could use it in a future IVF treatment cycle, okay? So you have to take it out and freeze it and then use it in the future. And I have seen men who've had testicular cancer or even, total body irradiation for stem cell, produce very small amounts of sperm, but you can find it.
Another one that's been asked a couple of times, thank you, is if your oncology team at the beginning, which is what happened to me, actually say there is no time for your fertility to be preserved because of or need for treatment, would you advise people to maybe seek an opinion, a second opinion, or would you advise that they proceed to treatment and then worry about the fertility afterwards? I think that one's come up a couple of times. What advice would you give if that was the advice that somebody was being given?
So we're really talking about getting a second opinion on your oncologist. I'm always one for getting a second opinion because, first of all, 2 local consultant urologists told me my husband had an infection of the prostate and refused to believe he might have cancer, which took me to find a third opinion, a consultant in London. He was diagnosed 3 months later and the cancer had spread outside the prostate. The second thing is 2 years later when it came back, my husband was told, I'm really sorry, there's nothing more we can do. So I explored and got second and third opinions and we managed to get him onto chemotherapy trial, and that's why he's here. So I'm sorry to say this, but I am a medical expert, but I don't trust every medical expert that tells you that's the only way. It's only because I'm tenacious that he tells me this, that he's here, and it's because I didn't take the first answer for granted. I didn't believe the first answer. So sometimes it's his worth, but it's not easy to do in the NHS. And I'm really sorry to say that, but it's just the NHS doesn't give you that pathway of second and third opinion.
Thank you, Carol. And then we've got another one here. Do they do testicular or ovarian tissue freezing?
Yes, and I didn't touch on that because they are still research centre driven processes. So if you happen to live in Oxford or you happen to live in Edinburgh, which are the 2 main centres that offer that sort of freezing, you may get that opportunity, but it's primarily for prepubertal people rather than people who are able to ovulate or have eggs. So girls under the age of 14, boys who haven't gone through puberty.
Thank you.
On that front, just very quickly, on the testicular and ovarian freezing, there are several people in SHINE, definitely in their 20s, potentially also in their 30s, that have had ovarian tissue freezing. But as I understand it, it is a very cutting edge technology, and the kind of evidence base and the data on success rates compared to egg freezing isn't yet very well established and known. That the data on live births is extremely high because everybody wants to record that, right? It is kind of cutting edge technology, but it won't be available everywhere in the UK. Unfortunately, a lot of this is a postcode lottery, which can be really difficult, but we all know that for cancer treatment anyway.
I would say that's a very, very good overview of the situation as it is. I know that I've had patients that have had successful treatment with, so when the tissue is frozen, it can then be thawed out, transplanted into a suitable position in the body, and then hormonal stimulation is used to activate that bit of tissue to produce eggs that can be harvested and used in the IVF process. But it is, I think place like Belgium, you know, they've got probably even more data there. Not a huge amount of data yet in the UK. It's going that way, but it's so non-accessible still. You should, if you want to try that, you've really got to be in the right area. That's the
yeah.
way.
Yeah, so just very quickly on funding and areas that people live in, the NHS is going through a transformation at the moment. What was the local CCGs, as some of us will know, are now called, sorry, that's my doorbell ringing, I think. The CCGs are being kind of grouped up into even larger areas. That every single borough, so for example, in London, I live in the borough of Lewisham, their funding policy stops at 38, doesn't fund single people. Wandsworth and Merton, which is where my hospital is based, where I have all of my treatments, they fund up to the age of 42, and they do fund single people. So it really, there's such a huge discrepancy. There are unfortunately places that have stopped funding all IVF now. I think Croydon may be one of those. But ask your GP and ask your oncologist, because they should know the answer to that question.
Thank you, Jess. Sorry, there's loads of questions coming in, and I know sadly we're not going to be able to ask all of the questions today. I think one higher up, when we talked about the sort of age profile of women and cutoff periods, is there sort of an age profile, or is there a reduction in sperm once males get slightly older, or is the impact less significant than it is for females?
You can be a sperm donor up until the age of 45, and thereafter you will start to see more errors. Genetic health of the sperm is not as good. But as we know, you know, men can father right up into their 80s, 90s. So it's not so much of an issue as it is in women.
Oh, hang on a second. Sorry, I'll just mute Jess. Sorry about that. And then, sorry, let me find, I think we've probably got time for one last question. So should an embryo transfer be funded? I was told that it wouldn't be. I'm 30, I've got no children, and I've got a long-term partner. Two are frozen in the freezer. This is my first time doing IVF. The IVF part was funded, but I was informed that the next steps wouldn't be.
I'm really surprised to hear that, because the NHS has frozen the embryos, presumably, and that to me is a logical. It's actually cheaper for the NHS to fund a frozen embryo transfer than to do a fresh IVF cycle. So it is worth questioning the CCG as to why they've done that, because I've had patients who've had frozen cycles from material they've frozen.
Thank you, Carol.
I think just very quickly, Hannah, if I can say to everybody on the chat, if you've got a question that hasn't been answered, please put it in the chat. Hannah and I will go through all of the questions and make sure that we cover as many as possible. And we'll be a little bit cheeky and ask if Dr. Carol can potentially go through some of those answers with us. We have all of your email addresses because you signed up to Shine Connect. So we can try to send those out to everybody. I'm not promising that's definitely going to happen, but that's what we're really, really going to try for, because this has been such an amazing session. It is so refreshing to hear a doctor speak on the cutting edge research, but also in such an inclusive manner, covering all genders and sexual orientations and relationship structures, because that unfortunately is something that is not equivalent all over the UK. There's loads of questions we haven't had time to answer, but I don't know whether Hannah has got any concluding remarks.
Can I just make a suggestion? I often do Instagram lives, and I can speak with Hannah about doing a follow-up Instagram live one evening, and through the Agora social media. I'll very happily do a half-hour live question and answer, and that might be quite nice for you. It just an easy way of, if you want to moderate it, Hannah, or something, I'm very happy. Then we can follow this up in a week or two with more questions, and other people may then have seen the video or anything.
That would be fabulous. If you don't mind, Carol, that would be great. I'll speak to Kaimin after the session and we'll get that set up. If you have got any questions that you've not managed to get into the chat today, I'll post something on the closed Facebook group. And if you want to add your questions onto that about the fertility session today, we'll make sure we capture those and we'll then get those to Carol up front before we meet again. If you can just bear with us, the session today is recorded and it will appear on our website shortly. But as you on quite a lot of sessions this last week, so there's going to be probably a couple of weeks before they do appear online, but by all means do get in touch with us and ask your questions. But thank you very much for everybody's attendance today, and we'll pull the session together and get it out to you soon.